Thank you. So I'm from Alabama. So we don't say good afternoon. We say roll tide. That's why come on, you big blue people, you can join in. That's if you're not. So thank you to the leadership, the planning committee, Miss Ali, who I've never met, but thank you, wherever you are. The people that hooked me up, thank you. The guys that brought the chairs up, thank you. The guys and people that served the snacks that you seem to be enjoying so much, thank you too. So let's say thank you to everyone. All right. So let me see here. So this next 30 minutes, I'm going to share my heart with you. And for some, it may cause some heartburn, but it's with love. And for some, it may be tough love. But tough love in the end pays a dividend. So we're gonna talk about some topics that I think are critical at this moment in healthcare, whether that's here in the U.S. or globally. So I'll start with why. Well, let me start with who, because I think who comes before why. Who are we doing this for? Who are we serving? We're serving vulnerable populations. If you look at the data, then that tells you why. We do too much harm in health and healthcare. Not intended. We show up every day to do our work. And we try to do the best thing we can do every day for everyone. The data says, though, there is some difference that exists that we need to talk about, because that difference is causing harm. This is the Chicago loop. The per capita income in the Chicago loop is a bit over $120,000 per year. I live 7 train stops from here in the Illinois Medical District, about 3 miles, 7 train stops. The per capita income there is about $26,000. If you go 7 train stops, the life expectancy drops 18 years. 18 years. A statin, which we love statins, will get you maybe another 2 years of life. And it's called a blockbuster. So here I'm talking about a blockbuster. Both figuratively, metaphorically, and in real life, it's a blockbuster from here to the Illinois Medical District. That's what we're here to talk about. But in order to talk about it, this will be news to some, old news to others. We need to honor history. We have to know how we got here. And I won't go back too far, but I'll go back this far because, again, this is Alabama, and this is the father of modern gynecology, who experimented without anesthesia on slaves that he owned in the state of Alabama. In Montgomery, where my grandfather and father were born. Henrietta Lacks, who was treated at Hopkins, and the HeLa cells now have saved who knows how many lives. They continue to save lives. And I'll jump ahead a bit and say that, and I'll hit back on this. The recent article in Science that talked about an algorithm that was found to be racially biased said that if Henrietta Lacks shows up at Hopkins today, and if we applied that algorithm, she would not have received care. I'm from Alabama. The legacy of Alabama and Tuskegee still lives today. The impact of what happened in Tuskegee, Alabama is alive today. It was not until 1977 that then President Clinton apologized. And he said it was an outrage. But there's one word in there that we need to take in right here, right now, today. So I'm what they call an African Methodist Episcopal Zion. So that means that at some point I had to sit on the front row in the church and commit. I had to make that commitment. So as leaders, what I'm going to say today is we got to make that commitment. And I'll ask you silently to find something here to commit to. So disparities. These are some of the numbers we know about. I won't read them all. You can look at those and see. These are real numbers. They are valid. They are robust. But guess what? They're also actionable. The disparities. These are real numbers. Heart disease, cervical cancer. We all know about the mortality rates in African American women across the U.S. This has been called a national disgrace. Shalon Irvin was a CDC epidemiologist. Shalon Irvin's mother testified to a congressional subcommittee in September. Shalon Irvin's mother called this a national disgrace. She said that this is more than access to care. And as leaders, we like to talk about let's improve access to care. The question is, what happens after you get access? Shalon Irvin's middle class, well-educated, had access to care. She died 3 weeks postpartum after repeated visits because she had access to care. Repeated visits when she tried to say, something is wrong with me. Help me. I don't feel right. Shalon Irvin went home and died. Her mother says a national disgrace. So what I'll say to us as leaders, we didn't break it, but we own it. The commitment is that we own it. We own it because 30% of black women feel discriminated against in a doctor's office. We own it because at the University of Virginia, residents and medical students thought that black skin was thicker, therefore didn't need as much pain medication, narcotic or not narcotic. Research shows the impact of no insurance, underinsurance, language issues, social issues, and how they impact access, utilization, and then outcomes. So then what are we talking about? I think we have to have a working definition or operational definitions of what it is we're talking about. So we're talking about health equity, but I would rather say health inequity. And here's some working definitions of what we're talking about, but let me put it a different way. And I'll put it a different way that applies both to disparity as well as equity. So in 1899, W.E.B. Du Bois wrote something called the Philadelphia Negro. 1899. And what he said in this treatise was there is a peculiar indifference that exists. A peculiar indifference. So then I would say, and I'll speak for Shalon Irvin and say, if I want to be as healthy as I can be, don't block my way. Don't put fences in front of me that I can't get over or under or around, because that is inequity. Because I want health and I want health care. Too many people don't want to be classified as a vulnerable population. We want to be called a healthy population. Don't block my way. If you block my way, you hurt me. If you block my way, you harm me. If you block my way, you make me wait. If you block my way, you waste my time. If you block my way, you don't listen. Dr. Shanafelt talked about humble inquiry. If you block my way, do you care? If you block my way, what is your intent? What is your intent? What is your intent? And what is your intent? Because intention is the predictor of the outcome. There are what we call vulnerable populations that go beyond the color of my skin. It includes what language I speak, how I dress, how I worship, who I love. It includes if I'm in prison or just got out. It includes if I'm overweight or obese. Care for me. Listen to me. Apologize to me. Don't be my accountant, be my caregiver. Cerner and Epic are not human beings. Look at me. So I say that because I have a friend who's a documentary filmmaker in Chicago who followed a young African-American male who was paraplegic. She went to a physician's visit with him. When they got there, she asked, "What do you expect in this visit?" "What do you expect?" He said, "The usual. Because I don't have a physician, I have an accountant. He never looks at me." You saw the photograph in Dr. Shannonfeld's presentation. He spent his time looking at the computer. And my friend asked the physician about that encounter and what this young man had said. His response was to her, "Why do you care about him so much?" Because there are hundreds of thousands more out there just like him. So it's a big question. Why do you care? We are caregivers. Regardless of what my ism might be, what that ism is that we all carry around inside of us. We are caregivers. Well, look at the news. And you can look at the news any given day. We talked about burnout. JAMA study that says residents are burnt out taking care of black people. The good news is it got better in the second year. I talked about the article in Science, a pediatrician in Philadelphia where a black child is 4 times more likely to die before he or she is 6 than a white child. Many of you saw this story. I had the privilege and the honor of working with, I think, one of the most courageous people in healthcare. And this is what he said. I was at Huntsville Hospital in Alabama when Chuck Stokes went into the OR and said to a rain-making orthopedic surgeon, "If you don't want to do the timeout, come with me outside and tell the family." What do you think happened? He did the timeout. But in those words, what does Chuck talk about? Commitment. He talks about who we are. He used some words that in equity work, disparity work, diversity and inclusion work are critical. Dignity and respect. Don't take my dignity. Respect me. I asked my barber, young African-American guy, what's the most important thing about going to see your physician? He said respect. We talk about millennials. We need to understand what respect means to millennials, specifically young black male. Don't take my respect. Don't hold my dignity hostage because maybe it just make you feel better. Or does it? So we got to start thinking about these things that exist, that we know exist, that are difficult to talk about. One is implicit bias, and we can talk about explicit bias because we know it exists also, but implicit bias stalks the clinical setting. It contributes to decisions that are made that lead to less than optimal outcomes. It makes me feel, as they say, some kind of way when I feel disrespected. It makes me feel some kind of way when I'm labeled non-compliant. I had that conversation with the leader in patient safety and quality when I was at the Joint Commission. African-American female who died. She died as a direct result of harm in the organization. What he said was, you know, Ron, she was obese. She was combative. She was non-compliant. So I think, I like cookies. In fact, I got a cookie in my bag back there right now. And nobody touch it. So I'm a little bit overweight. I don't always show up to my internist's office on the day that he wants me there because I might want to do something else that day. And I'll reschedule it. There are some days that little pill for hypertension, I just don't take it. And then those magical automatic refills show up and I'm thinking, I got pills left. Does that give healthcare the right to hurt me? To label me combative? Non-compliant? She was obese. Or what Malcolm Gladwell calls sizeism. So what happens then? I laid out the historical reasons for the mistrust that exist, not just in communities of color, but that other list I showed you. A good friend of mine, a pediatrician in Huntsville, Alabama, I saw her name in the paper a few years back. And I called her and I said, is this true? A child who was questioning was either taken or his mother contacted 23 different pediatricians before she accepted him as a patient. Everything from, I don't see those kind of people, or they would run off my good patients, or it's against my religious beliefs. I probably can't even count the times when people come to me and say, Dr. Wyatt, you tell me which doctor to go to because I don't trust any of them. Why? Because of Tuskegee? All they're going to do is experiment on me, like they did in Tuskegee. I don't trust. So what do we do to build trust? So that was an article in JAMA not long ago where a young African-American resident called himself a unicorn. Who saw that? Well, let me put it this way. I'm a unicorn. The number of black male physicians that matriculate from medical schools in the U.S. today are the same as it was in 1899. We need to eliminate unicorns. I don't feel special. I know that the Mayo Clinic applied implicit bias testing to the entire workforce. What were the results? They were shocked. Why don't people of color go into clinical trials? Or why is it that African American or non-white researchers have a difficult time getting NIH grants? So my sister ran clinical trials for Merck. The biggest challenge she had was convincing people of color to enter clinical trials because of mistrust. So we're here today to raise awareness, to acknowledge our history, to start to think about where we need to go. Or as Yogi Berra said, if you don't know where you're going, you'll end up someplace else. Where do we want to end up? Who needs to be included? Who needs to be made aware? All of these things build trust. Understand the history, how we address informed consent and research. Then the organizations we need to reach out to and say, we need your help. Here in Chicago is Westside United. I think there are folks in the room from Rush who are leading that effort. They went to the community and said, we need your help. So I'm going to propose maybe a new set of terms for some, maybe old for others, is that part of this awareness is we began to talk about competencies. We all know about cultural competency. So let's talk about structural competency. How we recognize the structures and institutions that are upstream. And how we began as leaders to begin to go upstream. Go upstream and see where the damage starts. What are the structures, political, economic, social, that are in place? And how do we shift what we see into what we learn? And from what we learn into what we do. So there's components of cultural competence that recognizes the structures, recognizes what happens in implicit ways in the clinical setting, how we respond to it. The underpinning of this is what's called structural humility. It's not do as I say because I'm the expert. It's tell me what I need to do because you're the expert to the person being cared for. It's showing that humility and that self-reflection that never stops. This is not a learning module that HR rolls out. It's a way of being. And it begins to take us upstream. The best advice given to me probably before I went into practice was from Dr. Venable, who was, I think, in his 90s in St. Louis. And Dr. Venable had 3 different practices at the same time. He gave me some good advice. And some maybe I can't use. Because he said if you charge everybody a quarter more, they'll think you're the smartest doctor and they'll all tell their friends come see you. That's Dr. Venable, that's Medicare fraud. But he said, when people come in to see you, you think you know everything because you just finished residency and you got a shiny gold watch and you just want to tell everybody what time it is. Put the watch in your pocket. Ask the person sitting in front of you, what time is it? And he said, they will tell you what time it is. That's when you bring all your medical learning and knowledge into the room. and you just say right back to them what they said to you and mix in some big medical science words. And they'll go out and tell everybody on the block, that's the smartest doctor in St. Louis. He told me what was wrong with me. Listen. Care. Be humble. That is strategic. That is executable. That gets the best results. But there's two hidden variables in there that would accelerate those results. Trust and being a leader. If you can bring those into that setting, you can accelerate everything else. Be a leader. Be engaged. Well, be activated. That's a higher level than engagement. Activate. Commit. From the C-suite to the boardroom. If we're serious about this, if we're committed to this, what is this? It's eliminating disparity, and it's achieving equity. It requires commitment. It requires strategy. These are the IHI strategies from their white paper. If you haven't seen it, you can download it. Make health equity a part of everything we do strategically, operationally and tactically. Have those conversations that we're not sure how to have. What are those institutional and structural processes that we need to deal with? Are we engaged around what we're going to call the multiple determinants of health? Housing, transportation, safety, lived neighborhoods, who gets contracts in an organization? As someone said, are we addressing health care? Do we provide a living wage? Is that too difficult? Is it too difficult to say thank you? I asked an environmental services worker 2 weeks ago at Stroger Hospital, what's most important to you? And this is a typical answer, everything's fine. And that was about 6:30 in the morning. So I said, okay, now we're past that. Now tell me what it's really like. He said, I'd like to get paid more, but that's not the thing. That's not the thing that hurts me the most. I show up, he said. I don't call in. I just wish that someone in leadership would sometimes come by and say thank you. We have to talk about racism, institutional and structural racism. I'm not talking about personal. We've got, as leadership and organizations, bring this in the room and talk about it. It is that other piece of the elephant that's in the room. How many women are on the boards? How many women of color are on the boards? Do they come in as a staff nurse and leave 20 years later as a staff nurse? What are those numbers? We have them. Do we partner with our communities? Right here. Per capita income in the loop, over 120,000. You go 2 blocks over, and there are people sleeping under the bridge, and I got a minute left. That's our community. That's the guy that used to be an accountant that's now hooked on opioids, that's now sleeping under the bridge, that the tourists don't see because he's invisible. But what does it take to get this thing to this thing called equity? Because if care is not equitable, I assure you, it is not safe. But it takes something that Dr. Wisdom mentioned. Having these conversations, digging into the data, understanding the community takes heart. And again, it can give you heartburn. It can break your heart. You can end up with a lonely heart. You can be heart sick. You will heal. It takes courage. The root word to courage is corde. What's corde? Heart. So this is not hard work, it's heart work. If you don't have the courage, compassion falters. This is from a Navy SEAL. He said, if you don't have courage, compassion falters. If you don't have compassion, courage has no direction. This is for our people. So thank you.